Hello, everyone. Welcome to Rheum Now's Rheumatology Roundup, a live session presenting highlights of the 2021 virtual meeting called ACR Convergence. I'm Jack Cush with Rheum Now. I'm joined by my good friend Artie Cavanaugh from UCSD and the Center for Innovative Therapies. We're coming to you live from the garage and dining room, and yes, we are wearing slippers. In this program, we'll be discussing abstracts and presentations of interest in this year's meeting. Please note, the abstracts were chosen without influence from the society, industry, people we play Doom with. Artie, what's the Minecraft? Is that the better game?
Minecraft is back again. Yeah, it's it's the thing now.
So
Fortnite's yesterday.
Yeah, so we're instead of watching abstracts, we're doing Minecraft. But anyway, abstracts were chosen because of their innovation and impact on practice. This is a live session. This is our uncensored views on these topics. Reproduction of this award-winning live streamed event is heartily encouraged because it's the internet. We can do whatever we want to do. I want to encourage the audience that if you have questions and comments, put them in the chat box. We'll be monitoring those and hopefully getting to some of them. I want to say that Rheum Now's coverage of this event has been bigger than ever. We had, at this point, over 1,300, almost 1,400 tweets, 143 videos. Our Twitter account has had like almost 17 million impressions. I mean, this is the way of the world. Artie, you're on Twitter, right?
I have heard of Twitter and the Book of Face, but I am on neither.
All right. With that, Artie, why don't you start us off?
All right. Well, thanks, Jack. Thanks to the Rheum Now audience for being here at Rheumatology Roundup. Maybe the people who are on the West Coast can share with me, since the meeting was supposed to be in San Francisco, why did the virtual meeting start at 4 a.m? Just asking. And I think like most of us have been going to a lot of the meeting, trying to capture all the good stuff and really try to bring some of that to you. So I'm going to start out with one of the late breakers. Usually Jack and I like to walk the poster room, the poster sessions, and just go up and talk to people. And of course, you can't do that at the meeting, but still, there was a whole bunch of presentations. This one happens to be one of the late breakers. This is L19. This was the Titane study, which, for those of you who remember, it was a secukinumab study. The secukinumab psoriatic arthritis studies were called Attain, so this is Titane, I guess, keeping with it. Anyway, small study, phase 2 study of secukinumab in giant cell arteritis. So talk about an unmet need. You could argue about the rationale and say, would you expect it to work? Would you not expect it to? But the results, I thought, were really quite remarkable. The study design was biologic naive patients who were either newly diagnosed with giant cell arteritis or were flaring, relapsing, and they were treated with a steroid tapering design because you can't not treat. The primary endpoint was those in sustained remission. And sustained remission, this came up in the questioning, it was defined clinically, no signs and symptoms, and also low acute phase reactants, but it would seem to be more clinical judgment than anything. Anyway, looking at the primary outcome, which was the sustained remission at week 28, very dramatic difference between the groups. You're talking about 70% with secukinumab versus 20.3% with the placebo group. Week 52 results, likewise, as remarkable, 59.3 versus 8%. The steroid doses were lower, not through the first 28 weeks, because that was pretty much how the protocol is written, but then after that. And also the time to flare was longer with active treatment. So very positive study, and I think very exciting. I think polymyalgia rheumatica, giant cell arteritis, a tremendous unmet need. And this was a study that really, as a proof of concept study, showed a tremendous value. And it was presented by Jens Thiel from Germany, and he said that even though this is in the time of COVID, they recruited the study faster than anticipated, and the phase 3 is just started. So certainly eagerly await that study, that larger study.
So I attended this session, and I sort of expected that there was going to be a positive result with rituximab and EGPA. There was not. And I didn't know what to expect with this targeting IL-17. But yeah, I think it was a bit of a surprise. I think all it was good. Ninefold higher odds of being in sustained remission on secukinumab if that compared to placebo. I'm a little disappointed in the size of the trial. Only 52 patients split between the two groups. I'm a little disappointed in a lot of steroid use in the first 6 months, which sort of obscures the true benefit of the drug, and it's not until the second 6 months that it really shines through. But I think that this is another way of approaching GCA. The problem is we've got tocilizumab approved for GCA, and I don't think anybody's using it. I think rheumatologists are still stuck with steroids.
Well, I think we almost have to go with steroids, and I think the approvals for tocilizumab are always much easier for someone who's been on steroids, and that speaks to the study design, as you're saying, Jack. You can't not treat with steroids because that is the standard of care. But I think this was, as you just say, it's very small, but it was very promising. The SAEs were actually lower in the active treatment group with secukinumab than they were with the placebo, which kind of makes sense because steroids can give some side effects. Infection is a little bit more with the secukinumab, but I think this was very promising, and I certainly look forward to more studies of this. In a way, it's certainly a brand new, but secukinumab is not a new drug. We really know about it because we've been using it for years now in psoriatic arthritis.
You know why they chose this as a target? I mean, IL-17. I mean, they're
the immunopathophysiciology of all of our rheumatic diseases. It's pretty much like a murder mystery. The way you get it is you write the last chapter first and then you work backwards, and you can always create a rationale. Going forwards, we don't do so well. IL-17 should have worked in IBD, and not only did it not work, it caused more problems. Actually, they didn't see any IBD in this study. So I think you could make a immunopathophysiciologic rationale. It's more involved with acute inflammation and neutrophils, but also has diverse effects on other cell types. So I don't know that I would have bet, if I was betting my money, that it would have worked, but it did.
Yeah, it certainly did. My first one is going to be one that I spotted many weeks before the ACR began, and that's the ARIA study. This is a preclinical RA intervention trial with abatacept or placebo. This is 100 patients enrolled, 98 treated. They were enrolled if they had arthralgia and a positive ACPA test and evidence of inflammation by MRI. And this was a 6-month trial. The idea was to treat them with either placebo or abatacept for 6 months and then stop drug and then follow them for another 12 months. This is basically the 6-month results. And it was, to me, surprising because I kind of expected maybe a marginal effect that might not last. But the primary endpoint was MRI improvement. That was seen in 61% on abatacept, only 31% on placebo. But more importantly, how many developed new arthritis? It was more likely developing an RA with placebo, 35% versus ABA at 8%. And there were more early terminations on the placebo group. Nothing surprising as far as adverse events. And the two things that are a little bit concerning here, one was the people who enrolled had almost 2 years or more of arthralgias at the time of enrollment. So is that truly a preclinical RA subset? It's hard to know. They had not developed synovitis. These patients had an average of 3 tender joints and no swollen joints and a pain score of about 4.3 out of 10. And the second point is that when asked the question, Jürgen Recht actually said that this was the follow-up, the 12-month follow-up off drugs still favored abatacept, but they're waiting on the results of the MR studies at 12 and 18 months before they can release that data. So I think this is encouraging. I don't think this is yet something I want to start treating my patients with, but I like seeing progress in the field of preclinical RA.
Certainly a super important topic, and they're definitely big proponents of it. So why do we wait until someone has really fully established rheumatoid arthritis before we start treating? We don't do that with cardiovascular disease. We don't wait until someone has their first MI before we lower their cholesterol. But of course, it's fraught with difficulties, including the earlier you go, the further away they are from really fitting the classification criteria of rheumatoid arthritis, the more you'll see spontaneous remissions. Now, limiting it to seropositives goes a long way for that. but still there's a big danger of overtreating. I think generally we consider abatacept for 6 months to be relatively benign and overall as a course of therapy. But I think that's been a big consideration, both ethically and as, of course, as far as study design. There was a study of methotrexate called PROMPT. There was a study of rituximab called PRAIRIE, but only a single treatment. There's a study of hydroxychloroquine. There's a study of the statins, which stopped enrolling. So there's been sort of not been a lot for this, but this was, I think, promising. But we definitely have to see those results further down the line.
Right. Yeah, and there are some studies that are still in progress. One with abatacept and another one with hydroxychloroquine. Maybe in the next year or two, we'll see the readout on that.
So the next one I wanted to cover, some of this was presented at EULAR, and I kind of wavered on this. This was abstract 1789, and this is the prediction of psoriatic arthritis in patients with psoriasis. And this is from Daphne Gladman's group in Toronto. And the reason I thought this was good is I think it's spot on for addressing a super clinically important question. We know that of the patients who have psoriasis, about 20% of them or so will go on to develop psoriatic arthritis, generally 8 to 10 years later on average, some even longer. So there's a story there, and we know it's genetics. It may explain some of it, but not a lot. So probably a lot of it is epigenetics, environmental exposures, and they're talking about even the exposome, the things that you're exposed to in the environment that may influence the development of disease. And this has been a super hot topic this year. There have been several publications in the Annals of Rheumatic Disease and in other journals looking at the clinical question of, if you take psoriasis patients and treat their psoriasis very thoroughly, do you prevent them from getting psoriatic arthritis? And there are data on either side, which speak to the difficulty of doing an epidemiologic study such as this. Now, in this abstract in 1789, what they did is to look for genome-wide methylation changes. And I think that they have a great population. They had patients, psoriasis patients, that they followed over the years, and they had half of them who developed psoriatic arthritis, and then they had those who did not. So I have a nice matched set, and they were able to, using the fact that they did or didn't develop it, they were able to find differentially methylated positions that separated those two. Now, this is, of course, would have to be validated. This is really hypothesis generating, but I think this is where the answer is going to be. I think in some years when we're doing RheumNow 2085, or maybe we're not doing it, but rheumatology roundup from ACR RheumNow. I mean, we will know the answer to this. Will be, oh yeah, we know this. This was like never eat yogurt, or always eat yogurt, or eat yogurt with a good olive oil or something. We'll know something. The microbiome is probably involved as part of the exposome, but I think these data are relevant, and it's kind of a super hot, interesting topic.
Yeah, I've been reporting that stuff where is psoriasis preclinical psoriatic arthritis, and does intervention, you'd think we'd be further along there, but we're just like we are in RA. We're kind of in a quasi land as far as the results. I think, yes, we need research like this to help pave the way on what to do next. Since you're on the topic of psoriatic arthritis, I thought it was interesting. I don't know that it really changes things, but it's still scientifically compelling to look at the study of monozygotic twins where they're discordant as far as their psoriasis. So the index case has psoriasis, but the monozygotic other twin does not. And they did basically microbiome analyses. And they looked at both the skin and the gut, and they showed in the gut they had an abundance of a loss of Ruminococcus bromide, and that was sort of unique here. And they sort of postulate in the skin. They also found certain changes, I think, that were enticing, but interestingly in the scalp, but not on the elbow. So that's a whole nother microbiome that's in play here. I think it does say that there probably are differences here that may result in risk. The question is, like other microbiome studies, how predictive are they, and how do we modulate that?
Yeah, I thought that was fascinating and amazing. I mean, to get nine pairs of twins discordant for the psoriatic disease, because not uncommonly, it's one of the stronger genetic diseases we see in rheumatology, isn't it? So I thought that was amazing. And of course, the issue with all these studies always ends up being, is it chicken or is it egg? Did the development of psoriasis alter their skin microbiome, which you sure think would be reasonable, and alter their gut microbiome? And I didn't think in this they explored so much the effect of potential treatments, which of course could also impact the microbiome. But yeah, I think this line of research is super interesting, and I think is going to be definitely going to end up showing us something.
That was abstract number 0944. Sorry, I left that out.
So the changing disease is, of course, a super hot disease that we've heard a tremendous amount about. Is lupus. There were from the FDA session, they said, look at all the new things we have, and you have voclosporin, you have anifrolumab, new treatments for lupus, and a new indication for belimumab for lupus nephritis. So lupus is very hot these days. A lot of research activity going on in that. Kind of a funky abstract I picked was 0340. I think it was interesting for a couple of reasons. It was an international collaboration with some investigators from China, and also with Chandra Mohan, who's in UT Houston now. And it was looking at urinary L-selectin. And urinary L-selectin predicts disease activity and histologic changes in lupus nephritis. So they had, it was a lupus cohort in China, and they looked at 197 lupus patients, compared them with 33 patients with chronic kidney disease and 27 healthy volunteers. And they chose to look at urine L-selectin. As Jack knows, the endothelial adhesion molecules really have a warm spot in our hearts, because that's a lot of the research we did when we were both back actually at the lab with the pipette. But they looked at this, and what they found, it was the urinary L-selectin levels. Of course, they correct them to urinary creatinine, were increased in active lupus nephritis, correlated with disease activity, and was able to discriminate better than things like C3, C4, and double-strand DNA titers, correlated with SLEDAI score, and also with the histopathology, both with the activity index and negatively with the chronicity index. They also tried to tie in the urinary L-selectin levels with the different patterns of immunohistopathologic involvement in lupus nephritis. So this comes on, the last couple of meetings that we've had, and there's actually an abstract 1937 that looked at urinary IL-16, which is a pro-inflammatory cytokine, and we've talked about that before. But boy, what a tremendous advance it would be to have a urinary marker of disease activity. I mean, how often does it happen in the clinic that you have a lupus patient? And that's the question. And we're measuring protein, but that's slow and indirect and really speaks about damage. We're looking at C3 and C4, which in an individual person can work, but in a group of people, it may not work. So, and a urine test, non-invasive, and also could be mailed in theory. So it's a lot of excitement with that. And since now we're finally having the ability to have additional treatments for lupus and lupus nephritis, I think that was like super important.
Yeah, it's as you were reciting the advantages and the correlations with clinical status and things we usually measure, it reminded me of the abstract that you also referenced, the IL-16 from Fava last year that we were so high on. And I'd like to see more of that and more research on that. And this L-selectin seems like it is following on the same lines. The problem being that proteinuria isn't all that good a marker. And that's one of the things that we continue to hang our hat on when it's actually been proven to misguide us. not in all patients, but in too many where we do need a better biomarker. So I think that's a major advance. I want to speak about another hot topic from last year. This is abstract 1426. That hot topic was the VEXAS syndrome. It was a plenary session presented by Marcela Ferrata from the NIH. She's a fellow doing fabulous work. We also did an interview with her today. You might want to look at that video. But what she did was she showed that in a fairly good-sized cohort, over 80 patients with VEXAS, they analyzed the mutations that they have linked. And so, of course, there's a mutation, a somatic mutation in the UBA1 marrow cells. It's found, it's X-linked. It's only in men. It's mainly seen in older men. These patients were accidentally discovered when they did some gene studies on them last year, and it was discovered in 2020 when there was one paper. In 2021, there's already 45 papers, and they saw that these patients all look like relapsing polychondritis, or they had skin disease that looked like sweat syndrome. And then they found these vacuoles, and that makes up the acronym that's VEXAS. And anyway, the outcome of these patients is sort of a mixed bag. Some do okay, mild disease with chondritis of the year. Some, die. The 10-year survival on this is about 50%. So their analyses looked at the gene substitutions, specifically valine for methionine at pMet41, and they also looked at a leucine substitution and a threonine. But this pMet41 valine substitution is a bad player. Older people, survival less than 20% at 10 years, and so that's an important thing. So they found from their study, predictive of poor outcomes was this particular valine mutation. And the other thing that was predictive of was the patients who had recurrent transfusions, meaning they probably had bad hematologic and marrow disease that they were requiring transfusions for their anemia. So since you can't do the genetic testing, it's not yet widely available. Dr. Ferrata suggested one way, the algorithm they came up with was if you see patients with especially relapsing polychondritis, Sweet syndrome, any kind of vasculitis, and they have a high MCV and a greater than 100 and a platelet count greater than 200, you might want to do some genetic testing. David Beck at NYU does a lot of this testing. He's seen a whole bunch of patients in the last year. And again, other than sending someone to the NIH or to NYU, right now it's having a high index of suspicion.
Yeah, when you hear the presentation on VEXAS, the presentations, I think everybody's first thought is, oh my, I might be missing this. I might have missed a couple of people with this and dismissed them. And I think it's still very early in terms of what do you do for such patients? I mean, of course, everybody gets steroids because everybody walks in our door gets steroids. But that seemed to be a pretty big unmet need. And somebody's raising the question now. Yeah, I don't think, from my listening to their lectures, I don't think there was necessarily a preferred treatment. And that's bad because there's a pretty high morbidity and even mortality with this. And the other thing I think that raises is, this is super well defined, and they found the mutation in the gene, and how many other somatic mutation diseases are we missing? These adults who spontaneously develop rheumatic disease, we hadn't paid much attention to that. But here, and they're harder to look at because especially somatic mutations might be restricted to certain cell lines. So that's a challenge. And it's certainly the people who live and breathe the autoinflammatory syndromes, they're aware of this sort of stuff, and they know what they're looking for with these. I think a lot of us don't, and it's a challenge for sure.
70% of patients followed at the NIH autoinflammatory fever clinic do not yet have a genetic diagnosis. 30% do. If you're out there wondering, I'm never going to see a VEXAS, that sort of thing, data presented by Dr. Ferrata said in a large cohort of relapsing polychondritis patients, 8% or 1 in 12 actually had these mutations. So this is out there. The treatment, there isn't anything. It's largely supportive. High dose steroids are commonly used. There's a number of anecdotal reports suggesting tocilizumab is effective. There's a few cases that from the NIH says that giving IL-1 inhibitors, anakinra, led to skin lesions and necrosis, and that was a sort of bad choice. So think about IL-6, think about steroids, and obviously when they're really bad, supportive care.
All right. My next abstract, it's 507, and this is tocilizumab in patients with new onset polymyalgia rheumatica. So this comes from Vienna, and also, unfortunately, a small number of patients enrolled in the study. But I think it was worth highlighting because the results are pretty notable, and certainly say that we should absolutely look for this. It's something we're sort of familiar with because the association of polymyalgia and giant cell arteritis, and also because we have such tremendous unmet need. I personally am a methotrexate PMR non-believer, although I think some of our PMR patients are more RA-ish and they may have some peripheral synovitis, and then I think methotrexate is reasonable. But as I look at the data, and this has been reviewed, and it's sort of I don't believe it's a valuable therapy. Methotrexate, I don't think, is a valuable therapy for most of our patients with polymyalgia rheumatica, and that's a tremendous unmet need because now we have steroids. So in this, they had a small number of patients, 36 patients, randomized to tocilizumab or placebo. The primary outcome was glucocorticoid-free remission at week 16, and this showed a tremendous difference, 12 of 19 or 63% of tocilizumab patients compared to only 2 of 17 with placebo, so 11.8%. Also, the time to relapse was better. So overall, really striking sort of results. Pretty much everything they tested was positive. The cumulative prednisone dose, the time was lower. The time to the first relapse was longer. So small numbers of patients enrolled in the study, but I think crucially important. And I'll add in kind of a mulligan here, although it's not my study, but in a way, this makes total sense because of the prevalence of polymyalgia rheumatica in patients with giant cell arteritis. We know that. And there was another poster from Europe, this one 0466, and it was subclinical large vessel vasculitis in polymyalgia rheumatica. So they talked about the potential relationship, and half of giant cell arteritis patients may have polymyalgia. The other way around doesn't work. It's only about 15% of polymyalgia patients will get giant cell arteritis. But what they did is took newly diagnosed polymyalgia rheumatic PMR patients, polymyalgia rheumatica, without any signs suggestive of giant cell arteritis, and they used hip and shoulder ultrasound and looked at 5 vessel territories bilaterally: temporal, carotid, subclavian, axillary, and femoral arteries. And if they found the halo sign, which you can see in vasculitis of larger vessels, that was considered a positive finding, as was an intima media thickness of 0.344 in the temporal artery, 0.42 in the common, and 1 millimeter in the common carotid, axillary, and subclavian. What they ended up finding was that it was 22% of the patients with polymyalgia rheumatica had positive ultrasound findings of the vessel. So is this subclinical giant cell arteritis? Obviously, it'd be super interesting to follow these patients along and say, well, what happens to them? They go on to frank giant cell arteritis. These are the patients maybe you'd want to treat earlier with tocilizumab, or in the future, maybe secukinumab, but tied in with the positive effect of the tocilizumab in polymyalgia itself. I thought these are exciting data.
The question is, will they move the needle? Steroids, really cheap, really toxic. Tocilizumab, really expensive, but much safer compared to steroids. And why shouldn't they be used more in GCA and also in PMR? where, everyone does the same thing. Sir, you have a new diagnosis of polymyalgia rheumatica. How long am I going to be on steroids? Well, probably a year or two. The data is very clear. Everybody's on steroids for more than 5 years because we can't get them all. Is that uncontrolled inflammation, or is that, unable to distinguish that from steroid withdrawal syndrome, which is a really big problem in someone starting on steroids? So I like these studies. I think we should be using less steroids. I think we should be using more biologics or more truly effective therapies, but that's not currently an indication. That would be an off-label use, but I don't see why the companies don't actually go for that indication. That'd be my suggestion. I want to go to not the lies that doctors tell themselves, but maybe what patients are telling themselves about the therapies they take. This is abstract 1158 from Caleb Michaud. Caleb did a follow-up study to something that happened long ago, 2006. Dr. Fred Wolf, long before that, I think he started it in the 30s, his national data bank with a bazillion patients. Back then it was already 17,000 patients.
In the 30s?
Oh no, it was he got the first. He was using the first handy computers. I think in the late 60s is when he started. It might as well have been the 30s. The funny thing about Fred's abstracts, because when we used to review abstracts back in in the 80s, 90s, and we used to get these abstracts and they were blinded. They would like white out the author's name and like the institution where they came from. But you knew Fred's abstracts because it was 34,000 patients were followed for 14 years. Nobody had data like that other than the National Data Bank and Fred Wolf. Hey, Fred, hope you're listening. So anyway, Caleb has taken on this data bank, and now it's now called the Forward Study. Back in 2006, I thought Fred wrote a seminal paper, which was, why do patients, what are patients' beliefs about their drugs and the drugs that they take? And he made the very clear statement that patients were unwilling to change for fear of what may happen. They would rather stick with the devil they know, having partial or even poorly controlled disease, as opposed to going to a new drug, which, the doctor is raving about it, but I don't know. I get all the bad stuff. They have every patient thinks they have the sword of Damocles over their head and that all bad things are going to happen to them. But that was a key takeaway. And it fits in well with human psychology and the Ellsberg effect, where we will all avoid ambiguity at all costs. If you don't really know what you're stepping into, you're not going to make the step. And so that was a take-home message. And so Caleb actually repeated the survey in a different era, 2021, and compared the results of 2006 and 2021. The bottom line is that while patients have changed and drugs have changed, while drugs have changed in that time period, patients and their behaviors really haven't changed that much. So they had thousands of patients, but they did have a cohort of 442 patients who took both surveys at both times, and their behavior was largely the same with a minor sort of change as far as why won't you change? Well, I'm still worried about risk of side effects. My doctor thinks is the best therapy. I'm worried about loss of control. I don't know that medicine is really going to be better for me. It just turns out that in 2021, there seems to be less buzz or less worry about insurance and the cost of medicines, which was obviously a big thing back in 2006. So I think this is still tells us we have a lot of work to do in trying to communicate and educate our patients and turn them into good patients. No one knows how to be a good patient, and we're supposed to teach.
Well, I think, I think this is, it's nice to see, but it's really incredibly evident in the clinic. I think when you talk with individual patients and you say, well, you could do better, and then the patients say, well, I could do worse, because they remember they were at one level of disease activity and they got better, and you want to get them to a new level. And I think that's the essence of what you were saying. What humans tend not to do is they don't want to take a risk to get better if it means a risk of doing worse. They're the conservative in that way. They don't want to do worse. And I think that undermines a lot of the whole treat to target issue. Treat to target sounds great. And of course, who wouldn't want to treat to a target of zero disease activity? Well, everybody would, of course. And I think the risk sort of matters. And we see that as well. And it's interesting because I'd love to see this survey give people different choices, like raising the dose of methotrexate. That's not that big a deal. But adding a new drug to your methotrexate, that's a big deal. Or changing this drug to a different drug, that's a big deal. And I think I bet people would vote that same way. But I think, we see this in the clinic all the time. Remember, Jack, we did a poster from not the past EULAR, but the one prior, where they had a treat target study. And by year 2, so patients entered the study, they agreed to the study. And the study was that if they were not at target, they were going to change therapy according to an algorithm. By the end of the study, most of the people were saying, nope, ain't going to do it, ain't going to change. They were good enough.
And the doctors bailed out and the patients bailed out.
The doctors bailed out because they said, well, maybe it's temporary, or maybe I'll just throw some steroid at them and they'll get better. And I think so but I think this really rings true. Anybody who said, you can get every patient to change therapy just isn't really, they're not seeing patients.
No.
So, all right, what am I doing next here? Let me see. I'm going to go with one that I think I liked because
it's like you're ordering from the menu. And, if I'm the waiter, I'm like, it's not the bar exam, Dr. Kavanaugh, choose something.
So we're going to change diseases to vasculitis. And I love this one because it agrees with me. So of course I like it. And of course it's right because it agrees with me. This is 419. Post-induction ANCA titer does not predict mortality or renal outcomes. A target trial emulation study. So that sounded very cool too. I'm thinking like that, the one of them Oculus devices where I'm a fake investigator examining a fake patient. But what they did is to take people from a large ANCA-associated vasculitis cohort that they have over 17 years. All the patients were positive for PR3 or MPO. They used a single reference lab for the ANCA titers. And then they looked at outcomes and did a lot of modeling to say, what happens if you get a negative titer with your ANCA or what happens if you don't? So they did 589 patients. They treated them as they were doing. First, it was really Cytoxan based. That more recently, it was rituximab based, and 48% of the patients got rituximab. About a third, 32%, achieved a negative titer with the ANCA after a year of induction. What does that matter? Well, it turns out, and they looked at according to a whole bunch of outcomes: risk of death, risk of end-stage renal disease, other sorts of outcomes related to the becoming negative, and it doesn't matter. And I look at this and I say, well, of course it doesn't matter. You have rituximab, which is going to have a dramatic effect on your B cells, decrease autoantibody titers, decrease other antibody titers. And that's a mechanism of action apart from any effect on clinical disease. Same with Cytoxan. We forget, especially our younger colleagues who are younger, who haven't used a lot of Cytoxan, it had an incredible effect on B cells and an incredible effect on antibodies and therefore on autoantibodies. So this comes up a lot in the clinic. I think a lot of the times our younger colleagues especially love tests. They love test results. Love to look at titers. It's like, it's the ANCA was 562. Now it's 550. It doesn't matter. It really depends on, you treat the patient based on signs and symptoms. The ANCA helps you with the disease diagnosis. It doesn't help otherwise. And there's really not a lot of point in chasing it or discussing it.
So is ANCA like the ANA or like the double-stranded DNA? ANA meaning once you're positive, who cares? Never test it again. There's nothing to be gained from that. And anyone who does repeated serial ANAs, you're just kidding yourself. That's a gigantic clinical mistake. But double-stranded DNA has some predictive value in some people, and you got to figure out who that works in. And that's been my impression with ANCA. It has some predictive value with some people. Were they able to look at something like that as a subset, and where it does seem to make some sort of sense here?
Well, I think it most importantly is a different cohort. ANCA-associated vasculitis patients, as we know, very sensitive to getting hypogammaglobulinemic with rituximab. Don't know why. there's a brilliant interplay between autoimmune and immunodeficient diseases illustrated, I think, in ANCA-associated vasculitis. So the people are so prone to get, and that's different than it is in lupus. So I don't think you can actually get at that answer, but I think it says chasing the titer isn't going to help you, because even if they get negative, they can still have bad outcomes with the same frequency as those who didn't achieve a negative titer.
Mm. All right, so I'm going to go with a simple one before we get into 1133. This is abstract 1909 from Hogue et al. This was a study of almost 20-something thousand patients with RA and lupus, and they looked at what compliance to antimalarials did as far as outcomes over time. The bottom line was that if you were compliant with just simply hydroxychloroquine, it didn't seem to change your mortality statistics, and that was the endpoint here. Cardiovascular death. But if you were non-compliant, you didn't do as well. Actually, let's look at the reverse. If you were non-compliant, that was what they compared it to. If you were compliant, it lowered your risk of cardiovascular mortality by 50 to 60%. So it's a very large number, and they did the analyses many different ways, and it was seen in both cohorts of RA and lupus. And I bring it up because I'm perpetually perplexed by non-compliance. It's the thing I don't know about, but it is. I know it's in the room. I know it's coloring a lot of my successes and or failures, and I just wish we had a better grasp of it.
Yeah, is there anything that's more important? I mean, I think I probably like many of us, if you have a young trainee, a medical student with you, they'll think maybe you're slipping a bit because you asked that same patient 3 times about whether they're taking their medicine. And that's the most important thing, I think, in our history. I think with the electronic record, the person who's bringing the patient back said, "Are you taking all your medicines just like it says?" And they're shaking their head up and down. Of course, the patient says yes, but the most important thing is compliance. And I think it's a moving target, and no drug is going to work. The drug that's going to be least effective is the one that you're not taking. So it's important. It just, I wish we had a better way of doing that. Maybe one of them watches, not my Timex, which is still analog, but one of them watches that, like, when the patient comes in the room and says, "Oh yeah, Dr. Cush, I've been taking that Bacrinol twice a day," and the watch is like, beep, beep. So here's a question about from Gerald Eisenberg. Chasing ANCA levels can be helpful in a subset of ANCA vasculitis patients. Requires some follow-up over multiple months before the relationship is clear. And I think that's what Jack was getting at, that you check double-stranded DNA a lot in your lupus patients, and some of them doesn't matter at all. And there are some that it might. And I think that's going to be, of course, that's going to be true. But I think overall, you can't count on that. And it's important to follow all the clinical information. So for my next one, I'm going to get into a topic we'll go off a little bit more on, and that is the JAK inhibitors. And I want to talk a little bit about some of the interest in a new JAK inhibitor. This is brepocitinib. I thought, isn't Brepo the Marx brother that never made it?
He's the one who doesn't make it to the movies. Yeah.
Brepocitinib, selective TYK2 JAK1 inhibitor in psoriatic arthritis, and this was presented at the meeting. Phil Meese did this, and they have the typical design with 3 different doses of brepocitinib or placebo. The ACR 20s were about 65 versus 45. They did see a nice signal in the skin. The PASI 75s were like 60 to 70% compared to 24%. MDA was notable in the higher doses. So they saw a lot of the good outcomes with the high dose. They saw some benefit in enthesitis. Then with the safety, and I think that's where we'll get into the discussion of JAK inhibitors. So it's a different, but is it different? We know that the FDA has had a lot of activity this year. We'll talk about that in the talking about the FDA session. Here, is this different than the other JAK inhibitors? Well, boy, it had a really a good profile in terms of side effects. No MACE events, no GI perforations, but they did see zoster in the active treatment and not in the placebo. And they did see a little bit more of a signal with the liver function tests, and also a signal, especially at the higher doses with the CK. So is it different? It had pretty notable skin effects, and we had seen some data with bimekizumab, which is a TYK2 specific inhibitor. So that raises the question about JAK inhibs in all of our diseases. Are they going to be, are different specificities based on in vitro assays going to correlate with different efficacy and, more importantly, with different toxicities?
So is this different than any of our current JAK inhibitors, which we say are, kind of selective, but in fact they're not. They do, you have to get more than one, and TYK2 is part of the same Janus kinase family, so it's not surprising that you're going to get a JAK and TYK2 at some point. And I think that the story is going to be told by whether you get more profound immunosuppression, maybe with more side effects, like you mentioned with bimekizumab, where you have the dual inhibitor of IL-17A and F, seems to be really good and is really effective. And I don't see this really big toxicity, but there really is more candidiasis events with bimekizumab.
I misspoke. Sorry, I meant deucravacitinib, not bimekizumab. Bimekizumab, IL-17 inhibitor, deucravacitinib, the TYK2 inhibitor. Sorry, thanks for correcting me, Jack.
Yeah. So no, I think I like the new introduction. But I'm immediately looking for an at least equal clinical efficacy number. But then I'm really concerned about whether you may by reaching across and involving TYK2. The deucravacitinib, the safety of that looked fairly good, and we're not seeing anything worrisome at this point. So, although it's very early in its development, but I think that we're going to have to watch this one just as well.
Yeah, so that raises the issue that we're talking about, and there was a very nice the FDA safety presentation. I don't remember looking and seeing how many people are there. It's always a very well attended session, and it really was very nice this year. They covered a lot of things. They covered emergency use authorizations for COVID, for our drugs, for tocilizumab and for baricitinib. They covered the new indications for lupus, like we talked about, and navacaban for vasculitis. But they had a lot. Dr. Rajpal did a great job talking about the oral surveillance study, which is a study of, Jack wrote in to tell him what session it was. Excellent. It's worth looking at for sure. Oral surveillance, basically, the elevator pitch, it was a FDA mandated study, post-marketing study as part of the REMS agreement, to look at a risky population, age greater than 50, with one risk factor for MACE events, and to look at the development of MACE and malignancy in RA patients on methotrexate, treated with 2 doses of tofacitinib or with TNF inhibitor, which was Humira or adalimumab in the US and etanercept in the rest of the world.
Yeah, and obviously this was a big ticket item. There were a number of abstracts on this. 858 was a plenary session with Christina Charles Shulman presenting the data on MACE events, and 1940 Jeff Curtis presenting the data on cancer events here. And I do think that there's a lot of discussion to be had here. As everyone knows, September 1st, the FDA came down with its decision, warning everyone there was going to be a box warning, not just for tofacitinib, the main drug that was in this 1133 oral surveillance study, but also for the other JAK inhibitors in this therapeutic space, meaning that baricitinib and upadacitinib would also get a box warning, worrying about cardiovascular risk and a cancer risk. Cardiovascular risk were MACE events. Cancer risk seems to be fairly clear that it's lung, maybe with some lymphoma and maybe some non-melanoma skin cancer numbers that are higher. The data always seems to be worse for the 10 milligram BID dose. That was true for the VTE warnings that came out 2019. That's made it into everybody's label, but it carries forward into this cardiovascular and cancer risk warning. Artie, there were some instances where the 5 milligram BID, the standard dose that we use, didn't seem to have much of a risk, right? Well, first let's talk about not being non-inferior, okay, and what that means.
Yeah, it's a tricky concept, and boy, we're all having to learn a lot more clinical epi than we learned when we were fellows. So the non-inferiority margin was set at 1.8, and you say, well, wow, that's big, and that means basically that the highest chance within a 95% confidence interval can't be that this drug is 80% more likely. And say, well, that's a lot. Why not make it smaller? Why not make it 1.3, which it had been? Trouble is it's the numbers. If you look at this study, it had 4,400 patients enrolled over years to get 100, just over 100 events, or a couple of hundred events for the different outcomes. So you're looking at numbers, and what this is really looking for a signal, if you will. And and then it's not non-inferior, which you always think, well, what does that mean? If you said that to your child, who's like, have you been smoking? It's like, I've not been not smoking. That it's not the same with being non-inferior, but obviously it raised the signal. But also, on the other hand, as we're looking at this, and in the presentation from the FDA, in the 5 different posters they also had a number needed to harm. And, so the difference between the drugs was, up near 100, or sometimes a few hundred people. So you'd have to treat a few hundred people with the TOFA. You would get one extra event for some of these, such as the cancer, compared to the treatment with the TNF inhibitor. So you got to put it into context. I think the good thing from these presentations were that it looked like you could say that really a ton of the risk was in people over 65 who were smokers. And if you take those things out, if they're less than 65, they're not smoking, and they don't have a previous cardiac, like a previous MI, the risk of the MACE events is really not that different, certainly with the lower dose.
Yeah. The numbers needed to harm from MACE was 412, and for cancer 275. And as we were discussing earlier, that's a fairly good number for cancer, but it depends on the cancer. If it's skin cancer, who cares, right? If it's pancreatic cancer, where you're not going to do so well, that's not very comforting. And so the other question on all of this is this JAK inhibitor gone wild, or is this TNF inhibitor doing a better job at cardioprotection? And we presented data last year that for the first time, I think it was the Swedes who were starting to show that with long-term TNF inhibitor use, they're seeing less cancers. Finally, you'd expect that if cardiovascular risk and infection risk and cancer risk is all driven by inflammation, shouldn't control of inflammation bring these numbers down? Well, the Swedes showed it last year, and it's been shown for a long time, beginning with Fred Wolf a long time ago, and many others showing that methotrexate, but also especially TNF inhibitors, are very good at lowering cardiovascular risk and cardiovascular death, especially when you're on drug for more than a year or two. And that's kind of what happened in this study. I mean, I think you could easily argue that it wasn't that the JAK inhibitor that's to blame here. I mean, it just didn't do as well as the TNF inhibitor. That's just a contrary view, but this study wasn't actually designed to answer that question.
And we'll have data, it'll be a while, but there is this very similarly designed study with baricitinib that's underway. So I think that'll help address the question of, hopefully, is this unique drug, which certainly FDA is treating this as a class. And I think that's the conservative point to say, well, there are similar mechanisms, they have similar patterns of AEs. Otherwise, you have to show us that you're different. And I think that's going to be the FDA position.
So someone asked us, does the risk of MACE the same between TOFA, BARI, and UPA?
We would have to see. And that would be very, very large study.
Right. There's no way of knowing. Another question from Eduardo Paivo asks, why is the NNH so much lower for cancer compared to cardiovascular? The study was basically a cardiovascular, bomb waiting to go off. They were age 60 smokers, not on aspirin, with one or more cardiovascular risk factors and family histories. So this study was more designed to have a cardiovascular readout than it would have been to have a cancer readout. It gets a cancer readout largely because of the age of the group being studied.
And
So,
the smoking, because
oh,
lung
yeah,
cancer
smoking was a
was
big risk factor. Yeah,
lung cancer was the most.
yeah.
We got a couple of minutes left, Jack. The topic we haven't talked about are there are one or two abstracts on that COVID thing.
COVID. Oh, you mean the flu? Yeah. Well, yeah. I mean, there was a lot of I think good presentations, and I think especially with around the issue of vaccination and are our patients immunosuppressed, and should we be worrying about them? I think Jazz Singh had a nice presentation. I need to find that. Is L19,
L17?
L17?
No, L16, excuse me.
Yeah, L16.
Yeah.
I'm just trying to there. No, that's not it. Anyway, the data was, I think, pretty impressive in that and they he drew his data from a nationwide registry that's linked to EMR. So it's probably the best and largest COVID outcomes registry. And in that cohort, they found already 500,000 autoimmune patients, RA, PSA, gout, vasculitis, a bunch of other things. And they looked at the influence of the diagnoses. They call those immunosuppressed patients. They compared them to non-immunosuppressed patients in that same EHR. And they look at the influence of the drugs that we use in treating those patients. And the readout, was that we saw more COVID infections, and these were breakthrough COVID infections. So this 500,000 people had already been vaccinated, and with 70% of the vaccine used was with the Pfizer-BioNTech vaccine. About 20-something% were getting the Moderna vaccine. But the data was same for both vaccines. But of the vaccinated people, the chance of getting infected was like 41 to 46 per 1,000. This is a breakthrough infection if you had an autoimmune rheumatic disease, AIRD, compared to 31 per 1,000 in the non-immunosuppressed population. Amongst our patients who might be at higher risk, it was RA, gout, vasculitis, and patients with multiple autoimmune diseases. Not sure what that means. That means it's probably diagnosed by a primary care doctor. But nonetheless, things that didn't pan out in this breakthrough infection were things like lupus, and actually the highest one was polymyositis and dermatomyositis. That had the highest risk. And then lastly, the drugs that seemed to have risk was mostly the biologics, and traditional DMARDs and targeted synthetics didn't seem to have a higher risk.
Well, the rituximab, I think, always shows up, and that's I think very consistent. The rest, boy, these data are, they're hard. And as somebody raised in the questions on the side, what about the confounding by indication? You're looking at breakthrough infections, but are you more likely to test your rheumatic disease patients than your non-rheumatic disease patients? They're going to the doctor more. They're filling out those questionnaires. Have you had loss of a sense of smell or a sneeze or things like that? So it's still, I don't think it's a very big worrisome signal. But I think, we'll have to see when all these data get put together. There are dozens of COVID abstracts, vaccine, non-vaccine, booster vaccine.
Right.
And I think we really need to, they're different one from the other. I think the message is with rituximab, you really have to watch. Otherwise, it seems like, the other risk factors still seem to be more important, overweight and age and such.
Yeah, age and those risk factors still are dominant in bad outcomes, and including in breakthrough infections. But I'm a little concerned about the messages we're getting from the GRA and from studies like this that are saying there's good diseases and bad diseases. There's good drugs and bad drugs. And, and I don't think it's quite that simple. I think that rituximab seems to be, a unique risk factor. But I think a lot of the bad drug associations are patients with active disease getting bad drugs or tough drugs. And I think activity seems to be the driving force to infection risk amongst our patients, more so than any one diagnosis per se or any one therapy. That's my take on the data thus far. All right.
So Jack, as we wrap up.
Yep. Next year, we're going to be where?
Well, we're going to be live in Philadelphia, and I don't Twitch per se, but I'm trying to convince Jack to start up a Twitter hashtag, bring Jack and Artie back to ACR for Rheumatology Roundup. I guess that's kind of long for a hashtag, isn't it?
that no one's taken it yet, so it's all ours. We're going to own it, and yeah, everyone should get to Twitter and let's start that campaign. Thanks everyone for tuning in. Tell your friends to watch the video. We'll see you next year.
Thanks, Jack.